My name is Stavros Spiliopoulos. I'm an associate professor of interventional radiology in the University of Athens, Greece, and I'm the primary investigator of the VOLA II trial. The idea of volume flow assisted angioplasty came up after extensive discussions with my colleague nephrologist Dr. Ioannis Giannikouris in Athens, while we were trying to overcome the limitations of fistulograms and thrill palpation in order to assess our angioplasty outcomes. So we wanted to improve that. We wanted to find a common language between interventional radiologists and nephrologists. And we wanted to be sure that the angioplasty that we have done has a functional improvement in this circuit. And I think that duplex ultrasound and volume flow measurements gives us that physiological endpoint that was missing from our angioplasty procedures in dialysis access. Now, the VOLA II trial was a two-center study which included 100 patients. It was a prospective cohort study designed to include patients in the University of Athens and the University of Patras, together with Professor Karnabatidis, Katsanos and Kitru. And we were trying to validate the initial results of the VOLA I study, which means that we tried to understand whether volume flow assisted angioplasty improves angioplasty outcomes, plain balloon angioplastic outcomes in AVFs. The VOLA II trial demonstrated in a significant sample of 100 patients that volume flow increase was an independent predictor of reduced reinterventions. The hazard ratio was 89 per 100 mils per minute of volume flow increase, which means that for every 100 mils per minute increase of volume flow, the relative risk of reintervention is reduced by 11%. And I think this is very, very important. We are currently investigating that. We are doing our statistics. Yes, there is a cutoff value that you should reach in order to optimize your outcome. But for the moment, I can tell you that we are introducing the higher, the better concept for volume flow. So you're trying for the maximum. And this is in analogy with cardiology. The FFR is exactly the same. The higher, the better. I think so. There is a very good correlation between these functional endpoints. Makes sense. First of all, each fistula has a limit. So you cannot increase the volume flow as high as you want. It is possible that a good goal for angioplasty would be the baseline volume flow value that the fistula had before dysfunction, when it was mature and functioning well. So, I mean, if a fistula was running with 1200 mils per minute, I think that's the goal of angioplasty. So you won't go further than that. I think it's logical. Duplex ultrasound and volume flow is an old tool, but now we have a new trick. And really, it has improved my practice. I feel very comfortable at the end of the procedure if I see a volume flow of like 1200 or 1400 mils per minute. I feel comfortable that this fistula will not end up to my lab again soon. So, and if you have a look at the VOLA outcomes again, you will see that the 3 months TLR-free interval with plain balloon angioplasty was 97%, and the 6 months was approximately 75%. What I'm trying to say is that if you have a look at the literature, these are extremely good TLR-free outcomes, comparable to those with paclitaxel-coated balloons. So I think and I advise everyone to use this tool because it will change their practice and improve their outcomes.